Hello, my name is Gabriel Soriano. My teacher is John Moscoso. My topic is Clavacizumab for arterial thrombosis thrombocytopenic purpura. First introduction. Arterial thrombotic thrombocytopenic purpura is caused by aggregation of platelets on ultra-large bone Williams factor multilemers. This microvascular thrombosis causes multi-organ ischemia with potentially life-threatening complications.
Thrombotic thrombocytopenic purpura. This is a concise presentation for medical students. Thrombotic thrombocytopenic purpura is abbreviated as TTP. It is a blood disorder that results in blood clots forming in small blood vessels throughout the body. Let us see about the etiology of TTP. The exact etiology is unknown. It is associated with viral infections, drugs, and autoimmune diseases. It is most common in women between 20 to 50 years. Now let us see about the pathology in TTP. There will be widespread hyaline microthrombi in microvasculature with no inflammation. Peripheral blood smear shows thrombocytopenia, schistocytes, and reticulocytosis. As you can see in this picture, there are many schistocytes and there is thrombocytopenia. Schistocytes are nothing but fragmented RBCs taking various shapes. Let us see about the clinical features in TTP. There will be neurologic deficits due to ischemia in central nervous system. There will be fever. There will be renal insufficiency, petechiae, and microangiopathic hemolytic anemia. Now let us see about the laboratory findings in TTP. The platelets will be reduced. LDH and indirect bilirubin will be elevated. There will be azotemia, that is, urea and creatinine will be elevated. Bleeding time will be prolonged and hematocrit will be reduced. Now let us see about the treatment of TTP. Plasma exchange and steroids are the various treatment options available for TTP. If you have any suggestions, please let me know in the comment section.
Application in medicine. Clavacizumab and anti-von Willebrand factor monocytic single variable domain immunoglobulin inhibits the interaction between ultra-large von Willebrand factor multimers and platelets.
We've presented a trial which is a randomised trial looking at a new type of therapy called an antibody. This is a very important molecule which can act specifically and be manipulated to prevent the platelet VWF binding. It was a randomised trial where patients received standard therapy and they either received drug or placebo before plasma exchange was started, and this was continued following plasma exchange on a daily basis for up to 30 days after achieving remission, and remission is defined by normalization of the platelet count.
What we achieved actually was the number of the days for the normalization of the platelet was significantly lower for those patients that they were treated with caplacizumab. And as a secondary outcome was extremely interesting that because we could see that for 30 days that patients were treated with caplacizumab, they were protected to have exacerbation. There was few mucosal type of bleeding, but in none of the patients there was a need to use the concentrate to solve the problem of the bleeding. So I would say all over, the drug could increase minimally the mucosal type of bleeding, but not significant bleeding episode that could create a clinical alteration for the patient to prevent the use of this drug.
The importance of this paper is twofold. Firstly, it's the method of action of the compound, which is really quite unique. It's not associated with significant side effects. It doesn't appear to be immunogenic. The second important, and probably the most important reason for this trial, is that we have always been stuck in the acute scenario of trying to achieve a rapid increase in the platelet count, which in itself is associated with a better outcome for patients, and that's exactly what's been demonstrated in this paper.
I think it could have two significant impacts. One is sort of decreasing the dependence on plasma exchange. Despite the advances in immune suppressive therapy, better plasma exchange, better supportive care, the 10 to 15% acute mortality in acquired TTP in an acute episode has not been impacted. And I think this has the potential to do that.
For me, the most important thing was, even if I'm working and I'm trying with the PECs to remove the platelet, I'm trying to do the best that I can do at the immune system with the immunosuppressive treatment, but the disease is too fast and I'm not able to achieve the result I want. With this drug, I can control the symptom. I can detach the platelet from ultra-large von Willebrand factor and not having the consequence damage of this microthrombosis and giving me time to move on with the other type of the facility I have. I thought that is fantastic. I mean, this is, I think, the reason why this paper is very much appreciated for the physician and also mainly for the patient, I would say.
Pros and cons. Caplacizumab was associated with an increased tendency toward bleeding as compared with placebo.
Acquired thrombotic thrombocytopenic purpura, or TTP, is an immune-mediated disorder caused by deficiency of ADAMTS13. ADAMTS13 processes large von Willebrand factor molecules into smaller functional units. Lack of ADAMTS13 leads to unrestrained von Willebrand factor platelet adhesion, causing microthrombosis, thrombocytopenia, and hemolytic anemia. Caplacizumab is a humanized bivalent variable domain only immunoglobulin fragment that inhibits von Willebrand factor platelet interaction and has been effective at reversing the thrombosis and hemolysis and correcting thrombocytopenia in phase 2 human studies. In this multicenter randomized placebo-controlled trial, 145 patients with a diagnosis of TTP based on clinical presentation who had had one previous plasma exchange treatment were randomized to 10 milligrams of caplacizumab daily or placebo, in addition to daily plasma exchange and glucocorticoids. The primary endpoint was the time to platelet count normalization. Patients who received caplacizumab achieved faster platelet count normalization than those who received placebo. At any given time, caplacizumab-treated patients were 1.55 times as likely to have a normal platelet count. The composite secondary outcome of TTP-related death, TTP recurrence, or major thromboembolic event occurred in significantly fewer patients who received caplacizumab. A greater proportion of patients who received caplacizumab had bleeding-related adverse effects, most of which resolved without intervention. The authors conclude that caplacizumab reduced the time to platelet count normalization and the incidence of a composite of TTP-related death, TTP recurrence, or major thromboembolic events. Full trial results are available at nejm.org.
Conclusion. Caplacizumab induces a faster resolution of the acute TTP episode than did placebo. The platelet protective effect of caplacizumab was maintained during the treatment period.
Acquired thrombotic thrombocytopenic purpura is a potentially life-threatening condition caused by an autoantibody to ADAMTS13. Reduced activity of ADAMTS13 leads to the accumulation of ultra-large von Willebrand factor molecules that can bind to platelets and induce aggregation, leading to systemic microvascular thrombosis. This in turn can cause severe thrombocytopenia, hemolytic anemia, and multi-organ failure.
Caplacizumab is a nanobody, a single monomeric variable antibody domain that targets von Willebrand factor and blocks interactions with the GP1b receptors on platelets. Investigators conducted a phase 2 single-blind study at 56 sites worldwide, randomizing 75 patients with acquired thrombotic thrombocytopenic purpura to receive either caplacizumab or placebo, in addition to standard of care treatment, daily plasma exchange, and immunosuppressive therapy. As compared with standard treatment plus placebo, standard treatment plus caplacizumab reduced the median time to recovery of platelet counts. Exacerbation of thrombocytopenia within 30 days after the end of daily plasma exchange was also less frequent with caplacizumab, but bleeding-related adverse events were more frequent in the caplacizumab group. Thus, caplacizumab induced a significantly faster resolution of acute acquired thrombotic thrombocytopenic purpura than did placebo. Full study results are available at nejm.org.
Thank you for paying attention.